When you look here at table 10.5, table 10.5 better illustrates this idea that I've talked about of um, broad spectrum versus narrow spectrum. Broad spectrum versus narrow spectrum. How many different bacteria or microbes can this antibiotic be used to treat? The smaller, the narrower that band, the fewer microbes it can be used to treat, the fewer things in a clinical setting you can use it against. You look at the far left over there, isoniazid. Isoniazid is an extremely narrow spectrum. It's only good for tuberculosis. That's it. If you got somebody with a staph infection, strep infection, whatever, not going to work. Not going to be helpful. On the far other end of the spectrum here, you look at tetracyclines. Tetracyclines are good for gram-negative, gram-positive, chlamydias, rickettsia. Only thing in this table you see it's not good for are few of the gram-negatives and anything mycobacterial. Penicillins are great for gram-positives because gram-positives have the thick cell wall. Penicillin, the different penicillins, are good against only a few gram-negative species, because remember, gram-negatives have that thin cell wall, and they compensate for this thin cell wall with dual membranes. So the majority of the gram-negatives, giving somebody a penicillin is not going to really do anything to help. Broad, sledgehammer, tetracycline. Narrow, the scalpel, tobramycin, polymyxin, isoniazid. Good for only a few or one bacterial species. So as a clinician presented with a patient, unknown infectious agent, you see the wound, you see it's infected, or you see the signs of the inflammation for an internal infection. You don't know. You haven't been able to sample yet. ID lab hasn't sent anything back yet. What are you going to do? Out of the gate, you're going to say tetracycline or one of the cephalosporins. Within 12 to 24 hours, when you get the results back from the ID lab, here's the microbe that we think is causing it, one or two microbes that may be causing the infection. Here's antibiotic susceptibility study. Tell you which antibiotic they are still susceptible at what concentration. Then you go from the tetracycline or the cephalosporins to something that's extremely narrow. A penicillin if it's a gram-positive, or some form of streptomycin if it's a gram-negative. That's why, as I said, from a clinical standpoint, it may start off, here's one drug, one antibiotic they're giving you. The next day, it's something different. Third day in your hospital, same drug, but a slightly different concentration, slightly different dosage. As more information becomes available, you change what the treatment is to fit the new information. Don't want to sit there and be on the tetracycline, for a week, the cephalosporin for a week, when you know that there's a specific drug that will treat at a specific concentration, will treat what's causing the infection.